Right. Okay. So this is a recording with Peter Lerpiniere, who's already said he's going to overtalk. So we might edit some of this. Peter, can you introduce yourself first, and then I'll bang a couple of questions at you.
Okay, yeah. Hi, I'm Peter Lerpiniere. I am the Associate Director of Nursing for Mental Health, Learning Disability and Older People in NHS Borders. I have 30-year experience of working in a variety of mental health settings, including integrated mental health teams, multidisciplinary teams, inpatient and community settings.
So Peter hasn't always had that grand title. We knew each other when we were both younger and fitter than we are now. When I was a newly qualified psychologist and Peter was managing a community mental health team in the north of the Borders. So that's how we got to know each other. So the purpose of today is just to ask you a little bit about how it is for other professionals working with psychology as part of a multidisciplinary team. So could you perhaps first start off with what additional skills or what can psychology be helpful with as part of a multidisciplinary team?
I think probably when I knew you was when I was getting my first understanding and first experience of working alongside psychology. So I was working in a service with social work, psychiatrist, occupational therapist, physio, nursing, and psychology, and the different conceptualization. So when you've been working in a medical model, as it were, when you're working with psychiatry and with nursing particularly, you have a very medicalized, pathologized model of practice. So you're looking for what is the underpinning pathology, illness, however you want to describe it. What I was working with, am I allowed to name names? I'll just,
yeah, I can always buzz them out. But...
You can, yeah. I was two people that spring to mind, Emily and John, who I worked very closely with. Emily, I largely managed her workload without actually managing her.
So these are both psychologists we're talking about.
Sorry, yeah. And the ability to conceptualize things differently was extremely productive for the team. I think we certainly didn't make best use of that at that point in time, but it was as we were coming to terms. So you have to remember, this was when integrated teams were just coming together, really, particularly. And so Emily was trying to do a bit of pushing water uphill. There was a certain amount of, well, we'll do this and you just do that thing that you do where you go and talk to people and we'll sort of tell us about it afterwards. Working with John and I worked with much more closely with the same kind of patients. So we worked much more closely with people with dementia with distress. And he and I had quite significant overlap in that field. Same time, actually, I was working with Ian James, or similar work I was doing with Ian James. Ian was responsible for the development of what was become known as the Newcastle model in supporting people with stress and distress and dementia. And it's that conceptualization which is different. So I think what nurses and doctors are often very good at is understanding pathology and how people are presenting. The difference that psychology brought and started to bring was much more around the formulation, the development of an understanding of a person's behavior in a concept of their understanding of the world, if you like. Go ahead.
Yeah, no, that's fine, because it's interesting that picking up on the idea of formulation, but also picking on the idea of how things have changed over time as well, because one of the examples that I've given in my bit of presentation for this is just saying that when I first started, it was a new team who'd never had psychology before, and there was a lot of bashing your head against a window, but realize, looking back over that, I know that I didn't do that very well, for one thing, but the other thing was, how could people be receptive to something they actually didn't know that much about? How then does a new psychologist manage that better, do you think? I put you on the spot here because I wasn't planning that question. But
I think that so what we've got better at, I think, is understanding that there are different ways of thinking about the world. So so my field of expertise was working with people with dementia, And if you, as I understand the way that I conceptualize dementia is it's biological in its origin. It's behavioral in its presentation, and it's almost social in its management. It's what you do around people that helps them to understand what's going on with the world. So if for me, what works most effectively is truly multidisciplinary working. And it's that understanding that I am a piece in the jigsaw. I am not the whole jigsaw. And whatever somebody else says, whatever their conceptualization. So as a psychologist, or as a nurse, or as a doctor, or as a social worker, or whatever, the bit you bring is what actually helps to support that person in their quality of life and their quality of living. So if you only try and understand the world through one modality, then you will make you will be less effective as a practitioner. So what can a new psychologist do? It's probably about recognizing the skills that other people bring as much as being confident about the skills you bring. It is that jigsaw. I think there are certainly, so speaking as a nurse, there are lots of nurses who are really quite defensive around working with psychologists because of quite often a psychologist
To be
will
honest.
well, quite often a psychologist will describe a model and go, well, what we're going to do is, I don't know, we're going to use a CBT underpinning, or we're going to use DBT or whatever. But actually, and the nurse will go, well, that's just the conversation I just had, and it is that sometimes that it's the model versus the therapist, kind of almost. The nurses often see themselves as the instrument of practice. There was historically there was a description of the therapeutic use of self, where a nurse would actually be, help someone to be in containment of their anxiety or the difficult or whatever, which has its place. But there is also different understanding of how can I move this person through and out the other side. So
see, we could talk forever about this, I think.
Well, we absolutely could. We absolutely
interesting, because I suppose because of, obviously I was a nurse first as well, and I thought my practice was okay, but it was very intuitive. So let's say, for example, that my life experiences hadn't given me that intuitive way of dealing with people, but it had given me quite a kind of cause-effect behavioural way of managing people, then my practice as a nurse would have been different. Whereas I suppose the difference, I'd like to think, with the psychology training is that the models, you are trained in the model, so you've got it, and then it should guide your intervention. You have less of a kind of trial and error approach in field.
Yeah, and I don't necessarily think that's wrong. I'm not going to argue on that, and I think that you will find lots of nurses with different types of skills and different presentation and different life experience, and there are some people who are very adaptable and will mold their skills or adapt their skills to work with an individual and say, you know what, actually this person needs more of me or less of me. This person needs more of that model of practice or less. It's almost, this person needs more sertraline or less sertraline. I am the prescription sometimes. There are also some people who are really crap at that. There are people who are really good at working with that type of people, but if you haven't got any of those, I'm redundant. I'll just sit in the office and make paper aeroplanes, and that's no good. So and that's, I think, when you're asking about multidisciplinary working, that's the blend. It is recognizing that people bring a range of expertise. So quite often I would say I would try and avoid getting psychiatrists to see my patients with dementia, because they came armed with a pen and always felt they had to prescribe something. And I'd make them leave their pens at the front door, and I'd say, I need your clinical opinion on this, and then we'll think about what we're going to do about it. So it is there are a range of tools within our armory as a multidisciplinary team. Some of that is about the ability to better conceptualize what is going on for somebody. Some of that is intuitive, some of that is pathology. It is getting that multidisciplinary set of tools, I guess.
Yeah. I'm aware that that I could talk to you for ages, and we probably will once I stop recording, but I'm going to stop recording now. So
Okay.
thank you very much for your insights for us, and all
Okay.
the students say thank you as well. Okay.
See you.